A very good morning to all of you. As I said yesterday, I thank Dr. Jayakrishnan for calling me year after year to this place where I enjoy sharing my experience and learning from others. So now it has become almost clear to us that fetal medicine specialists will tell us the anomalies that the babies are having and sometimes what to do with that. But definitely, once you are clear that the baby is fine otherwise, it is not acceptable that the baby goes through another insult at the time of labor or at the time of delivery or after that. So that's where the birth injuries, almost all the birth injuries, I would say, to the extent that it can be blamed on the obstetricians, that is iatrogenic. So let's see whether these birth injuries are inevitable, whether they can be avoided, or if not, what can be the prognosis of those. That's where my talk is placed. So let me say what is a birth injury. It's an impairment of the neonate's body structure, which was otherwise okay, or its functioning due to an adverse event that occurred at birth. So that's what I said. The baby was apparently healthy otherwise, both structurally and functionally. But it's only at the time of labor, birth, and after that, it goes through an insult which should be avoided. The injury may occur, as I said, during labor, during delivery, or after delivery also, especially in the neonates who require resuscitation in the delivery room. So the problem can be at all three levels. There was no proper monitoring during labor to pick up the ischemia maybe, or at the time of delivery, a wrong decision to use a wrong instrument, or after the delivery, no timely resuscitation. All these things contribute towards a birth injury, which can be structural or functional. The spectrum ranges from minor, which are luckily self-limited problems like laceration or bruising, to severe injuries that may result in significant neonatal morbidity or, unfortunately, sometimes even mortality, that is spinal cord injuries. So the incidence, fortunately, is less, 2 to 3%, but that's actually should be almost zero, because we should have a better understanding why these injuries occur. Sometimes it may be a bold obstetrician or a sort of adamant obstetrician who wants to deliver in a particular mode, whether abdominal or vaginal. So both are sometimes can be wrong. The scalp injuries, which constitute the majority of the injuries, like something like 80% of the injuries are scalp injuries. These are mostly lacerations and bruising. Whereas the major trauma, fortunately, again, it is lesser, that is 20% only, but these can be sometimes detrimental to the fetus, like fractures or neuronal injuries, extra or intracranial hemorrhages, hypoxic ischemic encephalopathy, and seizures. I vividly remember one of my good friends, orthopedician, used to tell, Murli, the problem with orthopedic field is that the problem that we create, iatrogenic problem that we create, is going to be, every day the patient is reminded of that problem. Whereas in medicine, if the patient dies, the sorrow or sadness is just maybe one day or for a few times. That doesn't mean that the patient should be dying or the baby should be dying. But what he meant was that if you create a problem which the baby will survive, but it has to endure throughout its life, that is a reminder for the baby as well as for the mother that this definitely could have been avoided. And she suffers every day, every single day, as long as the baby or the person survives. So the risk factors, that's where we have to understand very clearly which are the three risk factors. The increased risk for birth injuries can be either due to, of course, who are the stakeholders. Number one is the fetus itself is responsible for that. Of course, it is innocent. It's we who have to understand in which situation the fetus is the risk factor. Basically, it's a size, either a very big baby where you feel that I can pull through, or I can just manage. Or it's a very small baby where you feel that it's a small baby, it can come through. So both are sometimes can be risk factor. And of course, the presentation. Basically, the malpresentation, whether it is breech or transverse. Transverse lie, most of us don't dare nowadays to give vaginal birth. Of course, there's no question of giving vaginal birth in them unless we have done an antenatal version. Breech, many times we feel that we should get back the art of conducting the vaginal breech deliveries. It's nothing wrong in that, but we should properly assess and select our cases for vaginal delivery. Any single-minded view is not correct, according to me. That's what I have realized over the last 30 years. You should not say, I will deliver all the breech by vaginal or all the breech by cesarean, or for that matter, any other thing. Even cesarean section, should not be under the conclusion that it's safe for the fetus all the time. So we have to select our cases. The second, of course, stakeholder is mother herself. Again, size comes into picture. An obese mother will always have a very big baby, obese baby. And then, of course, a very short mother will have problems with the pelvis. And we always miss this cephalopelvic disproportion. Presence of pelvic anomalies is another thing which we normally don't suspect as long as externally the mother is fine. Maybe there is a pelvis kyphoscoliosis which you would have missed. Or there is some small problems within the pelvis. At the brim level, there may not be any problem, so we take it for granted that the baby can come through, but there can be isolated mid-cavity contractions or isolated outlet contractions. These are the things which will dupe us. Then, of course, finally, instrumental delivery. A wrong choice of instrument and wrong application of instrument or timing of that. And the last one, the true iatrogenic problem or the risk factor. The first two are also, of course, we have a stake there because we failed to understand the fetal factor and the maternal factor. But the last one was definitely our choice. So that's why it is a true iatrogenic risk factor. Now, among these, let's see which are the risk factors that increase the birth injury. Number one, macrosomia. As I said, when the weight is more than 4,000 grams. Now, it's very, very difficult to say what is macrosomia. Sometimes we say 3,500 grams, sometimes we say 4,000. And in odd situations, we would have delivered a 4,500, and that we will take as one single anecdotal experience as the standard. So it's very, very difficult. It's finally boils down to feto-pelvic disproportion or cephalopelvic disproportion that we have to be careful about. Again, these are all statistics, 4 to 4,499, twofold greater. And beyond that, it is 3 times. And beyond 5 kg, I don't know who is going to deliver beyond 5 kg, but at times it happens. We have heard some news that a big baby delivered and this and all. That emboldens people. And 4.5 times greater risk. Of course, since the statistics is there, that means somebody has had that kind of a delivery. And generally speaking, anything more than 4,500 grams will be 7.7%, which is very high compared to the total birth injuries of 2 to 3%. Maternal obesity, again, you go on to the other extreme. First of all, we may be wondering that how they conceived in the first place, because we say usually anybody more than 35 BMA, we don't even consider them for even IVF. But here, of course, we have seen, I have myself delivered many 120 kg women and all that. They sometimes spontaneously conceive or whether they conceive with aid. But whenever the maternal obesity increases beyond 40 kg per meter square, it may be due to greater use of instrumentation or the increased risk of delivery of a large for gestational infant. So weight does matter. Then comes the abnormal fetal presentation. We all understand this very, very easily. Breech presentation particularly has increased risk. Again, because we hear so much of controversy in different conferences and different review studies come at different times. At one time they said all primary breech should go for cesarean. Then there will be a review of that particular study and a larger study will be done. They say, okay, you can still, it's most natural. In fact, other day I was listening to a lecture. In that lecture, he was totally biased for breech delivery. He said breech delivery is the most natural way of delivery. He went to another extreme. Any extreme view is bad, anytime in any field of life. But he said, just patient has to stand up and breech will come out on its own. You don't have to. He, in fact, demonstrated one also, a real video. The baby just comes down like that. But then once you see such videos or such conferences, then you will change your practice. And that's what we should not do. We listen to some leaders and then we change our way of life and listen to somebody else and we change our way of life. That's where we go wrong. Like students always calculate the attendance. They know that 75% attendance has to be there. So they calculate and live on the edge. So the moment they cross, near 70, they start bunking classes. But then suddenly they will have to take a long leave because of medical illness. Then they will fall short of 75% attendance. Similarly, we go wrong when we take certain views or certain practice points. Operative vaginal delivery. Again, even though there are only two instruments basically that we use, forceps and vacuum. In fact, I remember giving how to choose the instrument in one of the conferences conducted by Dr. Geeta Arjun. There's so much to understand, where to use vacuum, where to use forceps, and definitely the sequential use is not at all allowed. That means if you fail with vacuum, you should not use forceps. If you fail with forceps, you should not use vacuum. But we all the time do that because we are biased. We have promised the patient that we are going to give vaginal delivery. So we try and we fail, and then hook or crook, we want to deliver the baby vaginally, and we miserably, miserably fail. And then we take them for a very, very late second stage cesarean section. There also we may fail. So both forceps and vacuum deliveries are associated with increased birth injury. Don't think that vacuum is easier or forceps is easier. Both of them have their own share of problems. The sequential use of vacuum extraction, as I just now said, whether it is forceps or vacuum, increases the risk of birth injury more than the use of either of the instruments alone. This is a big, big, big no. You cannot use both the instruments in a single person. So I'll just put a no for that. Then comes the other factors like increased incidence of birth trauma to the head and neck in male infants. Of course, I don't know whether there is any gender bias even at this level. Maybe males are a little heavier, or I don't know if they are bigger. Ultimately, it boils down to that, I would guess. And the babies born to primary. This we can understand. Primary, of course, is a untested pelvis, so we always miss the subtle CPDs, and then we may end up with problem. Small maternal stature, again, translates into CPD only, and the presence of maternal pelvic anomalies, again, is CPD. So in other words, a missed CPD, basically, will be an increased risk. Now, there's another concept of decreased risk of birth injuries. That's what people think, that maybe vaginal delivery is fraught with a lot of problems, so we'll straight away go to cesarean section. So in fact, this particular study almost tried to prove it, but I have put a question mark, obviously means the next slide is contradicting that. It is unclear whether cesarean delivery is protective. According to this healthcare cost and utilization project, nationwide means American study obviously, showed a cesarean delivery was associated with a decreased likelihood of all birth trauma compared with vaginal delivery. And statistics can be made any which way to impress us. Adjusted odds ratio was 0.55, but there was a problem. What was the problem? When the analysis used the definition of birth trauma developed by AHRQPSA, whatever it is written there, cesarean delivery was associated with an increased risk of birth trauma. So it depends upon what measure you take, how you measure and who measures. All these are important when we give out the results. So what was the problem? This AHRQPSA definition did not include clavicle fractures or injuries to the brachial plexus and scalp, which are more frequently seen in vaginal deliveries. So these were out. So that's why they said, okay, very, very few injuries, maybe just laceration or some bruises. These findings suggest that risk varies between cesarean and vaginal delivery, not because of the nature of the delivery, but it depends upon the type of birth injury, as well as type of definition or type of measurement or measuring scale that you used. So now I come to individual deliveries, having understood basically the risk factors. Soft tissue injuries. Now, these soft tissue injuries, the most common form of traumatic birth injuries are soft tissue injuries, including bruises and petechiae, subcutaneous fat necrosis, and lacerations. Of course, all these things are some sort of temporary things, as you can see that, and baby will easily get over that, not a major issue. But some patients will make it a big issue. Suppose they see some nick on the forehead, or if they see bleeding, they will make a big hue and cry about it. So bruising and petechiae usually are self-limiting and are often seen on presenting portion. For example, in breech deliveries, it will be seen on genitalia. In the vertex presentation and face presentation, they will be obviously on the head and neck. They will be usually present at birth, and they are not progressive, luckily, because they will heal. Especially face, as we know, heals faster because of rich blood supply there, and not associated with other bleeding. That's very important. If the baby doesn't have any other bleeding tendencies, then these things it does. Suppose there's a lot of hematoma, that can give rise to hyperbilirubinemia, also added problem. Close follow-up after newborn hospital discharge is recommended. As far as subcutaneous fat necrosis is concerned, it is uncommon and usually occurs in the first few weeks of the life as a result of ischemia to the adipose tissue, often adjacent to the bony structure following a traumatic delivery. Suppose you have held the bones properly, or you have done any manipulations to remove the particular or deliver the limbs, this can happen. Characterized by firm, indurated nodules and plaques on the back, buttocks, thighs, forearms, and cheeks. So the nodules and plaques may be erythematous, flesh-colored, or blue, like in any other bruise. Typically, this condition is self-limiting again, like the bruise will take maybe 1 week or 2 to subside, with resolution usually occurring in 6 to 8 weeks in certain cases. These infants require long-term follow-up for the development of hypercalcemia, which can occur up to 6 months after the initial presentation of the skin lesions. As far as lacerations, most common injury associated with cesarean delivery. Especially if you do late second cesarean sections, you don't know how much to incise, you will invariably put a nick on the baby's forehead. In a study of 3,108 cesarean deliveries, laceration rate was 3%. 78% of them were done when it was an emergency cesarean section, most often on the presenting part, typically scalp and face. Majority were mild, requiring repair with just the sterile strips alone, no need of suturing. However, 3 out of 97, that is almost 3%, were moderate to severe, located on the face or ocular area, and required plastic surgery or repair, especially if it is very close to the eyes. These are the very important and come under the major injuries, that is extracranial injuries. Caput succedaneum is not exactly an injury, but all of us know that it's an edematous swelling on the scalp above the periosteum, which is occasionally hemorrhagic. It presents at birth after a prolonged engagement. Let's say it was the occipito-posterior, so long engagement of the fetal head in the birth canal after a vacuum extraction also it can be seen. Unlike cephalhematoma, it extends across the suture lines, so along all the scalp. And generally, it's a benign condition and usually resolves within a few days and requires no treatment. However, the mother gets very anxious when she sees a big cap on the baby's head. On the other hand, cephalhematoma is a subperiosteal, that was above the periosteum. This is subperiosteal, collection of blood caused by the rupture of vessels beneath the periosteum, usually over the parietal or occipital bone, which presents as a swelling that does not cross the suture line. It is restricted to the suture lines. The swelling may or may not be accompanied by discoloration, rarely extends after delivery, and does not generally cause significant blood loss. However, it can sometimes have a big collection of blood, and that can give rise to bilirubinemia, hyperbilirubinemia also. It is estimated to occur in 1 to 2% of deliveries, and is much more common with forceps or even vacuum delivery. Ultrasound is useful to know the collection. CT MRI very rarely we use. Cephalhematoma, as I said, if it is large, that can be hyperbilirubinemia, but majority will resolve spontaneously again over the course of few weeks without any intervention, please don't put a scalpel and try to drain it. It can give rise to further problems. Now, intracranial injuries, these are more dangerous than the extracranial injuries. So, intracranial hemorrhage can be subdural, subarachnoid, epidural, and intraventricular. Of course, intracerebral and intercerebellar hemorrhages also can very rarely occur. The risk factors for, in general, intracranial injuries increases with, again, operative deliveries only. In unassisted deliveries, it was 3.7 per 10,000, whereas vacuum, it was 16.2. Forceps, it was 17%. So both vacuum and forceps can cause intracranial hemorrhage. This may be underestimation against 26% in spontaneous vaginal birth as per study that used MRI. So the more diagnostic tools you use, you will see subtle hemorrhages, and it can also be categorized. So it can be up to 1/3 of the cases. Subdural hemorrhage, although the incidence is rare, is most common type. And its location is between dura mater and arachnoid membrane. Risk factors, again, forceps and vacuum, even cesarean section. Presentation, usually baby will have seizures, respiratory depression, apnea, and neurological dysfunction. And imaging will clarify the matter, whether it is subdural, subarachnoid, or intracranial, intraventricular. Management depends upon the location and extent of the bleed, obviously. Most cases can be managed with conservative therapy without surgical intervention. Whereas sometimes you may need surgical evacuation if there are bigger increased intracranial pressure, and SDH that occurs in the posterior fossa may cause brainstem compression that requires emergent surgical evaluation. You know that anything in the posterior fossa can be very detrimental and fatal. Seizure disorders should be treated side by side with anti-seizure medication. As far as subarachnoid hemorrhage, it represents second most commonly detected neonatal intracranial hemorrhage, most often caused by rupture of bridging veins in the subarachnoid space or small leptomeningeal vessels. Although subarachnoid hemorrhage can occur with normal spontaneous vaginal deliveries, the risk increases with operative vaginal deliveries. As with subdural, newborns with subarachnoid hemorrhage most often present at 24 to 48 hours with apnea, respiratory depression, and seizure. Now, I remember when the question is, what are the causes of seizure? We all write, in the first 24 hours and then after 24 hours. So after 24 hours, you have to think of all these kind of hemorrhages. Diagnosis is again by CT. Treatment is again conservative only. Very rarely, subarachnoid hemorrhage can cause post-hemorrhagic hydrocephalus, so which requires some sort of surgical intervention. Epidural hemorrhage is very rare, unlike the subarachnoid and subdural. In neonates, it is found between dura and inner table of the skull, usually caused by injury to the middle meningeal artery. The rarity of neonatal epidural hemorrhage is attributed to the absence of the middle meningeal artery groove in the neonatal cranial bones, thus making it more difficult to injure the artery. It's not fully ossified yet. EDH is often accompanied by a linear skull fracture. If there is an ossified bone and that undergoes fracture, and if there are vessels there, that can give rise to this problem, often associated with operative deliveries in primipara mothers. EDH and cephalometama can coexist because of the injuries to the vessels, when accompanied by an underlying skull fracture due to communication through skull fracture. They present with non-specific neurological symptoms such as seizures and hypotonia. The diagnosis is again CT MRI. Patients with very small lesions and a stable clinical course may be managed with supportive therapy. However, surgical evacuation is necessary when there is evidence of increased cranial pressure and or if the EDH is very large. Intraventricular hemorrhage is the biggest problem that we face, and especially even without any instrumental usage, it can happen in extremely preterm babies, especially if you give vaginal birth for them thinking that they are very small. It is very obvious now that when the babies are less than 34 weeks or 1,500 grams, it is safer to do cesarean section, even though the patients may not understand that. When it's a small baby, why can't I have vaginal delivery? It is the intracranial hemorrhage, the sudden delivery of the head. That's why if at all you want to deliver preterm babies, it has to be delivered through a forceps in the safe cage of the forceps. Although IVH is usually associated with preterm delivery, It is also reported as consequence of birth injury in term infants as well, 4%, luckily, less. The risk of IVH increases with operative deliveries, even in these kind of babies. In the absence of clotting disorder or severe asphyxia, most IVH in term infants will resolve spontaneously with no long-term sequelae. However, for infants with IVH due to significant birth trauma, close monitoring is required due to risk of extension of hemorrhage into the surrounding parenchyma and development of post-hemorrhagic hydrocephalus. Facial injuries, mainly nasal septal dislocations, occur in 0.6 to 0.9% of the cases. These infants can have respiratory distress as well as, and diagnosis is made by rhinoscopy. Manual reduction is all that is required, but sometimes you may require little more than that. No treatment or delay in treatment can result in nasal septal deformity, which can be permanent. Ocular injuries, minor ocular trauma such as retinal subconjunctival hemorrhage, it can occur in a vacuum delivery. We had a situation like that, baby was blind. Luckily, they resolved themselves after 6 to 12 weeks. And significant ocular injuries are associated with forceps delivery. And that could be hyphema, vitreous hemorrhage, fracture, gland injury, and disruptions. So you require an ophthalmologic consultation and resolution through that. Fractures usually occur in the assisted vaginal deliveries for breech, or sometimes it can occur even in case of shoulder dystocia in vertex presentations. The commonest is the clavicular fracture, and luckily this is not of big consequence. Most commonly reported ranges from 0.5 to 1.6%. The risk factors are again operative delivery and shoulder dystocia. Sometimes in shoulder dystocia, one of the maneuvers that we suggest is a deliberate fracture of the clavicles, either one side or both sides, to decrease the bisacromial diameter. But usually we do these things for a dead baby. For a live baby, we don't do this. We have better maneuvers, McRoberts maneuver, and hyperextension of the hips, and then suprapubic pressure, and just gentle traction should deliver most of them. So presentation is displaced if it is completely immediately after delivery, crepitus, edema, lack of movement of affected extremity and asymmetrical bone contour can be seen. If it is non-displaced, there will be a delayed by the days or weeks until there is a formation of visible palpable callus. So how do you manage that? Management is usually, because clavicular fractures, infant heals spontaneously with no long-term sequelae. Reassurance is all that is required. Analgesics for the baby if it is crying all the time, and you can fix the elbow in a 90-degree flexion. Humerus and femur, usually they occur again in cases of assisted breech deliveries and during the, shoulder dystocia. Risk factors and presentation is decreased movement of the particular limb. All that you need to do is immobilize the limb like we do in case of adults, and if required, analgesics can be given. Neurologic injuries, whole lot of them can occur again in assisted breech deliveries, brachial plexus, phrenic nerve injury, facial nerve injury, and laryngeal nerve injuries, but the dangerous ones are spinal cord injuries. So these have to be very carefully handled. Injuries include spinal epidural hematoma. I'll take one more minute. Risk factors include forceps and breech delivery. Abdominal deliveries, again, in a desperate situation where you try to rotate the baby breech by holding the abdomen, which should not be done. It should be a femoropelvic grip. So the problems are uncommon. Usually it's a rupture or subcapsular hemorrhage into liver, spleen, and adrenal glands. Amount of blood loss determines how the baby will suffer. If it is a large hematoma or hemorrhage, the baby will definitely have a big abdominal mass. As I said, risk factors are macrosomic babies, breech deliveries, and instrumental deliveries. Ultrasonography is the best modality to diagnose. Management includes fluid resuscitation with blood products, depending upon the amount of hemorrhage. Very rarely, a laparotomy is required for that. So thank you very much for your patient listening. I hope we don't take any risk with regards to the deliveries of the babies and give them a healthy, bony baby. Thank you.
Thank you very much, sir. We are deeply appreciative for your being with us today, and we are extremely thankful for the knowledge and information that you have shared with us. And now, marking our gratitude, we would like to present a memento to you, sir. And for presenting the memento, inviting Dr. K. Jayakrishnan, sir, to kindly come over the stage and for presenting the same.